Portage County Health Care Center Committee meeting, recorded September 16, 2020.
.505 on Wednesday, the 16th of September. I call the meeting of the Healthcare Center Committee to order. And the first item of business is the public notice. Members of the public who wish to address the committee on specific agenda items must register their requests at this time with such comments subject to the reasonable control of the committee chair as set forth in Robert's Rules of Order. We've always been very sort of ebb and flow, and we'll try to keep with that. I will try to make sure everybody has a chance to speak. I will first go with committee members though. So the protocol is committee members, and then I will look to members of the public with some priority given to county board members and the executive, of course. Item 4, approval of the minutes. I'd entertain a motion.
So moved.
Motion by Reeser. Is there a second? Second by Robbie. Any discussions, changes, deletions, additions, modifications? Hearing none. All those in favor of the motion to approve, please say aye.
Aye.
Anyone opposed, no. Abstentions, motion carries. Item 6 is about the discussion and possible action on special meetings. I don't believe we've had any special meetings requests, do we? No, I didn't think so. So we will move on. We have no correspondence at this time. Next item is a report from Marcia, our administrator. So Marcia, you will have to go up there, please.
Thank you everyone for being with us tonight, and I want to be very brief because we have an extremely important presentation which we've looked forward to. So first of all, I want to thank our healthcare center team, a team of heroes. I could not ask for more, and I'd also like to thank everyone on board from our county level for the resource support that we've had, plus our community. It's been tremendous. Very briefly, as of my presentation tonight, we've had 2 positive tests. Both, very fortunately, were immediately mitigated. They were in the dining room, or the dietary service, which have had no resident contact, and all of the mitigation process has been dealt with very well. So we were fortunate to be able to have the team members either already out of the building or having had minimal team contact. So very successful handling of those situations. We also want to report that vaccines for flu are going on at the same time. And we currently, due to the reporting requirements and Tammy's diligence, are doing 2 times weekly testing to ensure not only the safety and well-being of the residents we serve, but the team members coming and going. And we were also very appreciative of the National Guard assisting us personally on Monday, and I salute the emergency government for helping us orchestrate that, along with Gary Garski and the team. I do want to briefly say that along with that, every day is a walk of complete PPE and donning of above and beyond. I would say we're at about 175% of everything that can be done. And I want, again, to share thank yous. I'd also like to point out, as we speak and hear from Mr. Peer today, that the trending since our March 13th full restriction has been one of a gradual downward occupancy, and due to the current status, we are at a non-admitting status. I want to thank again our internal team for making some smart decisions, and as of tomorrow, our last 4 residents living on the rehab area will be combined into our north and south wings. So for the first time, we will be operating with just the west side of the building. This is seen as a temporary downsizing situation to accommodate several things. 1, the safety and well-being of the residents. 2, our staffing efficiency and the handling of dietary and other services within just the west portion of the building. Team has been wonderful in allowing that to happen. Again, specifically, we'll talk more as Mr. Peer presents, but our occupancy for August was at 47.5. which falls well below our budgeted 68. However, again, for safe occupation and living situation, we've been doing that. But on a closure note to our life engagement and all of the team members, the residents themselves have, I believe, been very well insulated from the daily operational aspect, enjoying life, and truly having a very high level of successful window visits, electronic visits, and daily activities through one-to-one visits. And as always, I remain available both through the computer, chat, and the phone. So thank you, everyone.
Any? That's anyone? Everybody online, I need you on mute. Laura, please mute. Donna Wierzinski, please mute. Please mute your phones if you're able to. Thank you. Otherwise, it's a mess. All right, now moving on. Next item on our agenda. Any questions for Marcia, by the way, from the committee? Members of the public? Anyone online? And I will wait the requisite 6 or 7 seconds. All right, moving on. Next item on our agenda is the much awaited presentation from Clifton Larson Allen's principal at Michael Pier. He has been working on this. We expected it, of course, a long time ago. Unfortunately, COVID happened and he had to recalibrate, but Michael, the screen is yours, and I'm looking forward to the presentation. The floor is yours, Michael. You're on mute.
I know, yeah. There we go. Thank you very much. And before I even get started, listening to Marcia's opening remarks, I just wanted to thank Marcia and her leadership team for working with us and making sure that we got to today in a very challenging environment. It's it's not just Portage County Healthcare Center, but we're really all senior living providers across the state. And thinking strategically and looking long term can be very challenging, especially now that you do have an instance of COVID within the walls. So thank you again, Marcia, and make sure that you thank your entire leadership team on behalf of us. So I know that the materials were sent out in advance. I'd like to really start with kind of what is our objective for today. And what the objective is and unless Melissa disagrees, I don't think that we're looking to take action and necessarily take a vote today, but to have a good discussion, a presentation of information, and be able to ask questions of myself and review information and be in a position to start moving forward strategically. As you could probably appreciate, any decision on this magnitude, we need to have a strategic direction, and there's going to be a lot of decisions that will be subsequent to today and in any decision as you move forward. So I do want this to be collaborative, and I'm going to try to limit my remarks to be able to leave a lot of time today for questions as they come up. We talked about, Marcia talked about the challenges of the senior living environment, but I think that it is critical, especially in a time like today, to think strategically and think long term and where you want to be as an organization. So in keeping with that theme, and this would be the question I would pose to really start, is as a county, as a healthcare committee, what direction strategically would you like to pursue from a high level? And we're not to the point of saying, yes, we want to approve whether it be a significant renovation or addition or a new facility, but do you think that the county should be in the healthcare business? And if so, should they continue to operate as they are today, or do we take the recommendations that were laid out in this report and really move forward in a different way with a building renovation, potentially new services, maybe a new building for the health center. So at a high level, that would be the first question. And the answer to that question would take us in one of two paths. If you come back after today's session and say, I don't think that providing healthcare services is a primary responsibility of the Portage County residents and taxpayers, then would we look at either continuing operations without any changes as they are today, or potentially close or pursue a buyer for the campus? And if you say yes, this is a strategic priority for the county, then start down the other path and looking at, is there an opportunity to increase the value that we provide to Portage County residents, and also do that in a cost-effective manner, which would really be the next step of this process. So as I said before, we're not looking for a recommendation tonight, but certainly on the screen we have some key questions that I think the committee, throughout this evening and in the coming weeks should grapple with to answer, to make sure we have clear direction on the course of action. And I'm just going to touch on briefly before we move on to the next slide. Timeline is important. Making a decision and moving forward. It's my understanding, and having been involved with Portage County for a period of time, this decision process has been going on for a significant number of years. And being able to move forward, selecting a strategic path for the organization, and then holding to a timeline for certain key decision and milestones will be very critical as you move forward. So the first thing and I'm going to actually skip over this slide. I'm going to go to the next slide, because this really shows what I want to illustrate. And that's what we would call the status quo scenario. So status quo in this instance would be you do nothing as a committee, as a county board, and you continue to operate at 70 licensed beds in the current building. What do we think, based on current assumptions and revenue growth and expense growth over the next 10 years, what do we think this would look like financially in 10 years? And when we look at that, what we can see in the top graph is really a diminishing return. Our losses continue to grow year after year. Certainly the wages and benefits that make up a majority of the expenses of the organization continue to outpace revenue growth. When we look at Medicare and Medicaid rate increases year over year, we're looking at, in a good year, maybe a 3% increase, where benefits and salaries increase by 4%. So we have this negative inflation factor, which really leads to, before we even talk about census levels, really leads us to a point of diminishing returns. And then the bottom graph would say, well, if that's the case, then what is the anticipated impact to the tax levy? What's the unfunded loss of operating the health center if you have increasing losses year after year? And if we look at this, I guess it's not for me to determine if it's acceptable or sustainable, but there's going to be a continuing need to be able to fund those losses, to increase the funding from other county programs, to really be able to sustain the health center. If you don't make significant changes that would allow you to be efficient and to do the things that would really change the direction of the graphs on the screen. So I always think it's important to talk about the mission of the organization. Just real briefly, you know, to provide short and long-term care to the elderly of Portage County and the surrounding area is really the mission of the organization. And I don't think that that would change as a result of any of the recommendations that we've discussed with the leadership team. How is that done today? These are the service offerings you currently offer. As Marcia said, your short-term business is hurting right now, as are many of the skilled nursing facilities in Wisconsin. Hospital patterns and changing healthcare during the COVID pandemic has impacted that significantly. I do think that that is going to come back. The key question is whether that will come back at historical levels, or whether at-home programs such as home health will take some of that short stay skilled nursing business away from the nursing homes. You also provide long-term care, dementia care at advanced stages within the skilled nursing, and then hospice services. You have a number of partnerships that you provide hospice services through as well. So much of the information that we're going to provide today, and really the purpose of why we do, or why we suggested and they engaged us to do a market assessment, is to really look at what is the external opportunity that we have in the market area. So when we define the market area, we look at current admitting zip codes. So when residents move to the health center, what zip code did they originate from? And we're generally looking to get about 75% or more of the admissions when we define the market area. So we can see on the screen the area in yellow is how we define the primary market area. And that's important for two factors. Number one, we're going to talk about population trends and the ability to pay. So that area, when we talk about population increases or decreases in the market, it's confined to that area. When we talk about competitors that operate really against the county-owned health center, it's this market area. Knowing that, yes, you receive some admissions from outside of that, and yes, you would probably have competitors outside of that, but those are the majority of where those would come from. So and I always like to start with kind of the executive summary and then back into the details. You know, I think from a competitive summary standpoint, the health center it's a beautiful campus. You've got a wonderful park-like setting. You provide excellent care until today was the first I heard that you had a COVID case, and you're one of the few in the state of Wisconsin that had remained at zero incidents in skilled nursing. So I think that is one of the testaments to the quality of care you provide. Also, your 5-star rating is phenomenal and has been for a period of time. So you've got a lot of advantages when you talk about competitors and why people would want to move into the Portage County Health Center. The downside, well, and one more point on that, you also have 70 out of 130 beds in the market. So when we look at the skilled nursing service specifically, you make up over half of the skilled beds in that market area. I think one of the key challenges, and really one of the themes of this report, is that you are operating today in a building that is nearing 60 years old. The original building was built in 1964. I think I have that date right. It's on my next slide. 1964. So you'll be celebrating 60 years in that in just a couple of years. And when we look at the configuration of that building, as healthcare and skilled nursing services is delivered today, it's not really conducive to how we staff and being able to be efficient in staffing patterns and so forth. So I think that the physical building itself is always going to require you to staff higher than some of your competitors. There's also concerns with just the overall physical building and its relation to being able to provide quality care and just basic services. An example of that would be that you do not have central air conditioning. And as I'm sure as the staff would tell you, we had a very warm summer or a warm streak this summer. And they're not able to use enough window air conditioners for each resident room. If they do, that the electricity load on the campus is too much and they would not be able to use other healthcare electronic devices. So, you know, I think in the physical plant, there's a number of limitations that that would need to be addressed as you move forward. We talked about those. Lighting in resident rooms was another key point. Many of the resident rooms do not have adequate lighting, do not have lighting that would be, I guess, kind of a baseline expectation of residents going forward. And I think that as you have opportunities with Portage County and surrounding residents moving in, they probably look past some of those aesthetic aspects because of the quality of care. And you know, they would like to have those and they would expect those because they're seeing those lighting and air conditioning and some of those basic elements at competitors, but because of the quality of care, they get past some of those limitations. So what we would recommend from a skilled nursing perspective is to explore either a significant renovation or a replacement facility. Now with either one of those, there are a number of steps that would need to be explored. Again, kind of going back to that key point of is this a service that we want to continue to offer? And then asking from a high level, would we consider exploration of a significant renovation or replacement facility? We don't have enough information. You don't have enough information to make the ultimate decision that yes, you would move forward today. In my mind, one of the next steps would be having an architect involved, looking at even the potential and what would be involved with the renovation of the building. If you were looking at a new building, perhaps, location, what type of building, what size of skilled nursing is appropriate as we move forward are all questions that would need to be addressed. And you know, we need to certainly get past the first questions to get to the later issues and be able to make recommendations there. The second area is really what I would refer to as enabling technologies. As everyone can probably imagine, as we've gone through the last 6 months, healthcare has changed rapidly this year, but was changing very rapidly over the last couple of years. Being able to use electronic devices that allow physicians to do off-site monitoring of residents, electronic capture of medical record information is a fairly significant deficiency that we noted in our assessment. Currently, the system is, well, the system you're using is several versions behind what that organization would call their current version. But the electronic medical record you're on today is not one that's being used as widely. Many organizations have moved from that to other electronic medical records. And one of the reasons is, as we noted in our staff discussions, there are significant duplication of entries. Systems that are working outside of the electronic medical record do not integrate electronically into that system. So really what you have is a duplication of entry, where you may be working with a pharmacy system or a therapy system, and instead of that information passing through electronically, you have another person or persons that are rekeying that information into the medical record. So I think regardless of the building, this is certainly a strategic priority and something that needs to be addressed. The other component of this is looking beyond just skilled nursing. Today, you have a 70-bed skilled nursing facility, and certainly continuation of that is one option. But I do think that there are other services that should be considered as we develop a strategic plan. Working with other county departments to develop mental health services, and we could limit that to geriatric components of mental health services is one area. Really expansion of your dementia units, dialysis and home care being others. And we are going to talk about, potentially assisted living as maybe another option as well to explore. And then really the last part of the executive summary is what I would term as collaboration. So we have worked with numerous counties in Wisconsin that operate healthcare components, whether that be hospitals, mental health hospitals, skilled nursing, and so forth. And one of the ways that we've seen county-run organizations, and not-for-profit and for-profit skilled nursing providers be able to reduce cost is to collaborate with other providers. Being able to share some of those leadership services and knowledge, maybe even potentially sharing some of the electronic medical records, some of the billing software, those types of processes. And we found that to be very successful. So I think that as we look at the strategy of cost containment and trying to limit that decline that we talked about in the status quo scenario, looking at collaborative models, to me would make a lot of sense in collaboration with the other items that we talked about, the building infrastructure and the electronic capabilities of the organization. This in itself would not fix the problem, but it certainly would be beneficial. And I think it would lead to an improved outcome over that time period. So as we looked at the initiatives, and I'm gonna go through this pretty quick because I do want time for questions and answers. We really broke the strategies or the recommendation and discussion on strategies into 5 buckets. And that would be what we talked about with skilled nursing, not only the building, but the electronic capabilities and so forth. Potential development of assisted living, which I want to speak to because we haven't talked about that. Looking at amenities in the campus through a renovation or a new building, but also new services as being a big component of that. And then workforce development, because that continues to be a challenge to find a qualified and a workforce that continues to drive the quality services that you provide. So I'm going to, I think I'm going to skip over skilled nursing, and hopefully everyone is okay with that. I think we've talked about most of the key points with this. Actually, I'm going to hit on this slide because we didn't talk about it. But most of what we recommend and observations we've already spoken about with skilled nursing. What we have on the screen in the graphic is really what we, based on the market assessment, what do we think that the population in the market area is going to do from 2020 through 2025. And what we can see is assuming that skilled nursing beds remain the same at 130, the greater than 65 will increase. So you have the baby boomers starting to enter the market, which is what we expect. They start to turn 65, but they're probably in 2025, a 65-year-old in most cases is not who's getting admitted to a skilled nursing facility. So really what we're looking at is your kind of core admission is the 85 plus. And if we look at that during that time period, there's a population of about, we'll call 1,157 in 2020 that are 85 plus, and that essentially remains flat. It goes up by 30 people in the next 5 years. So, so we do have to, as it relates to skilled nursing, we don't see a huge pent-up demand as individuals get older, but as those 65-year-olds start to age, there will be continued demand as we move forward for these services. The other component of skilled nursing is really changing consumer preference. And this is why I talked about before when I spoke that I'm not sure that short-term Medicare rehab is ever going to go back to historical levels. That, as well as other things that are unrelated to COVID, is really changing how skilled nursing and post-acute services are provided. So what we've done in this graph is really look at and start with baseline demand, which would be demand today. So out of those 130 units, demand today would dictate that you need about 97. So there's, you know, approximately 40, a little less than 40 additional units in the market area than the population would demand. What we expect because of that increasing population is there will be some increased demand over the next 5 years, adding an additional need for 7 units to get it up to 103. But then external environmental factors such as hospital utilization rates of skilled nursing, shorter length of stay in skilled nursing, and other impacts because of COVID and other things. We think that's going to take about 15, the demand down 15. So overall, we expect in this market area that demand would drop just a little short of 9% in that 5-year period, which is one of the recommendations where we said, you know, potentially looking at assisted living or a different type of service may make a lot of sense regardless of what you do with the health center. So maybe a little background on assisted living. There are 2 types of licenses that an assisted living in Wisconsin can be licensed under. And I'm not going to get into the details today, but if you decide that this is something something to pursue, I think we do need to talk about what those license types mean in the future. But what we've seen across the state, really across the country, is that individuals continue to prefer and really move into what we would call the least restrictive environment. So if you have an individual that, let's say, is 85 and needs some care needs, they can't live independently, they need some support services and some skilled nursing care, but not 24 hours as in a skilled nursing resident, that they are choosing, if it's available, to not go into the skilled nursing at first and go into an assisted living where they can receive the services and the support they need, with the expectation that at some point their care needs may increase, and at that time they could move into skilled nursing. So I think that many market areas have seen this to be very successful, many organizations. And it is less restrictive on the residents, but it's also less restrictive on the care providing organization, meaning there's less regulations than in skilled nursing. So you have a little bit more latitude as far as staffing and some of the regulatory components of that. So if we look at really the external environment, so you have competitors in the market today that are offering assisted living, and the RCAC on the screen and the CBRF, those are the 2 license types that I spoke about before. But if we look at either one of the license type, we can see that there is unmet demand in the market, meaning there are individuals that are the correct age and have the correct income stream to be able to pay for assisted living services. So I would view this very much from an external standpoint as a strategic possibility if you chose to move in that direction. Amenities and services, I think we did talk a little bit about this. Certainly being able to provide some additional services not only creates some diversification in your revenue stream, but allows you to service more residents of Portage County. You may have mental care support that today you can't support, and being able to develop that specialty, that could be something that would benefit not only the revenue of the health center, but also really the overall health of Portage County. Expansion of hospice care, dialysis, home care options, all of those are possibilities, and again, ways to increase your margin and really take some of the pressure off of just having skilled nursing as you do today. So I think we covered most of the recommendations. If I was prioritizing these, I think that that having a strategic direction with skilled nursing, again, not committing to exactly what that might look like in the future or what size, but also consideration to, is there a housing or an assisted living component to that to really offset that? And would you be interested in pursuing some of the other service offerings that potentially don't have the capital infrastructure that either skilled nursing or assisted living would have to explore and really continue to reduce that tax levy and tax burden to the taxpayers. And then finally, workforce development. We talked about collaboration with other counties. I certainly think that is a mechanism that you can continue to reduce cost. Also be able to create an environment where you have good training programs, some networking with other county employees or employees of other counties is what I meant to say. I think it would be additive. One of the difficult aspects of working with county-run healthcare facilities is the benefit load. When we compare you or any other county skilled nursing facility to a for-profit or not-for-profit, one of the areas that always is higher is your benefit structure. That's one of the reasons that you attract and retain staff, but it also is added cost. So I think as we go through this, really reassessing what benefit are made available to the health center employees. And because if you're adding cost and there's not a perceived benefit and it's not enabling you to retain those employees, then there's not really value. So I think that would be a key component of this next phase. And with that, the following pages.
Buffer.
Market assessment. So we can refer to those if you'd like, but I'm not going to go through that tonight, so we can have some questions. So with that, I'll pass it back to Melissa and see if we want to open it up for any questions.
All right. There, I can switch back and forth. I'll get bifocals one of these days. Question and answer session starts with the committee members. And your mics are live, so you don't have to go up.
Just had a quick question. When you suggest about transitioning into assisted living and other supportive services, how unique would those services be in our current market, the market area that you identified? How unique would those particular services be compared to what's already out there or what might be out there through through private services, businesses.
If you, I'm going to skip to a slide that's in the detail that we didn't go through, just to give you a sense. Well, maybe before we even do that, this would be, these are where the current assisted living providers are in that market area. So you can see that they're around you. I would answer that question and say, I don't think that it would necessarily be unique. Part of that would be how you would design it and possibly make it different than other providers. But it would give you a complement and a continuum of care inside your current campus that you don't have. So I would use the term unmet need, which was really what I was speaking to on the original comments, and saying that right now the population trends would support more beds, more assisted living than what you currently have, even with this number of providers in the market. And I'm going to flip to another slide here. Oops. These are the units and the providers if you were interested in that.
The second question I had, at the very, very end of your presentation, you make a comment regarding turnover and benefits and weighing that out in the future as far as part of this ratio. And I didn't see it in the report, maybe it's there, but do we have information as to what our turnover rate at our facility is compared to the private practices within the service area?
We did not specifically look at turnover rate. We looked at the benefit cost as compared to other organizations, but we did not specifically look at turnover. My inclination in the conversations is it's lower than competitors, but Marcia could probably speak to that better than I.
Thank you.
Did you want to address that, Marcia?
I know that we also have human resources on with us tonight, but we do take pride in retention. However, I think COVID-19 has altered a lot of things. Laura's with us tonight as well. I don't have the specific turnover rate. I know that HR tracks that for us, but with the number of job openings recently, people have been seeking some employment opportunities outside of their normal healthcare realm. My honest feel is that we do a superlative job in retaining. However, we do see a continued turnover, particularly since we hire a lot of students, and they do move on both career-wise as well as to other areas. Laura, if you'd like to comment further, I'm open to statistics. But
I'll defer to Carrie or Susan because
okay.
they track it, I don't.
Yep.
So.
But I do know that from the private sector, there is an ongoing, probably close to 90 to 100%. We do not have that. Benefits are much better in our arena. That's a given, as is the longer-term longevity of leadership, which you don't see in other assisted living.
Sure. Thank you.
Thank you.
Marcia. Do you have more questions, Dennis?
I might, but I'll
Okay.
yield the field.
Well, we'll just go this way then. Ray?
I'll defer for right now, actually. Michael answered quite a few of my questions.
Okay. Mildred?
Well, I have is it Mike working?
Mike? Yeah, it's live.
You have to turn a little bit there, towards you. There you go.
There you go. It is live.
I had a question about 10 years. We were looking at 10 years out, but most of the information seems to go to 2025 and not to 2030. And I'm just curious about that.
That's an excellent question. I should have addressed that in my comments. I was trying to go there. I thought you were going to ask about that slide. So the reason that all the population information only goes to 2025 and not the 10 years that we show here is we buy population information from a third party, and that information is only released in 5-year increments. So Unfortunately, it's a limitation of the data. I would love to be able to project that out another 5 years. So really what we look at is a trend graph. So we'd go back 5 years, look at today, and then look out in the future. Because as you can imagine, population aging is linear. Everyone ages by 1 year per year. So we look at that trend graph and try to interpret that, but that's a data issue.
Do you have other questions, Mildred?
I'm not sure who this is a question for, whether it's for Mr. Peer or for us, but that is, what is the information in here that is different from what we already knew? I mean,
Yeah, go ahead, Michael.
Yeah, honestly, I'm not sure that, other than this information and data being more current than maybe what you knew when you began this process. It's going on 10 years, I think, when you first started talking about the future of the health center. The building was old at that point. It's gotten older. I'm not sure that anything other than possibly the electronic capabilities and some of the technology that is expected today, that would be a fairly new development, just because of rapid changes in the last 5 years. But much of the infrastructure is, like you said, probably very consistent with what you've been told for a period of time.
So, and bear in mind that we'll be back on September 30th for, basically, I didn't want to add in costing information because we still have, this was important to get context for our new members. And even though some of this is what we've seen in some of the other reports, like Michael says, we wanted to bring it up to date so we were current, so we couldn't speculate, well, we assume that the market has done this or that. So we still have a little bit more. And remember, North Central Healthcare has said that they would pay for a portion of this report as it related to, if we're interested, that collaboration with North Central, sort of that regionalized healthcare system for skilled nursing. So that still is out there, but we had to get the underpinnings done first. So good question. Does that correct analysis, Michael?
Mm-hmm. Very well said.
Thank you.
Michael, just one last question on my behalf, but how unique are we as far as a county? And I don't have this information. I'm not sure what your expanse of working out beyond Portage County is, but obviously we're kind of transitioning potentially from skilled nursing to assisted living. Obviously, we have a facility that does not meet current needs or current desires. Is that what other county homes are experiencing, or is this unique to Portage County? What's your experience out there? What's happening in other places?
Yeah.
Michael, before you answer, I think that Marathon County's process with Mountain View is probably a great parallel, and you probably have others, but that was one of the things I was going to say, bringing that parallel in as well, and it fits with Dennis's question. Yeah,
Mountain View is a great, I guess, case study that we could certainly talk about. But that committee, their healthcare committee, their county board ultimately grappled with the same questions that you're working through right now. They had a building, and I think one of the challenges is if you look at Portage County or you look at Mountain View, and you might go out there and say, there's nothing wrong with this building. Well, unfortunately, in the 60s and around that area, they built buildings to last, and these buildings are like bomb shelters. But it's really the ability to provide services in an efficient manner. And what they ultimately, Mountain View, decided was, yes, we want to continue to provide services to the to the residents of Marathon County, and then ultimately decided that we will build a replacement facility because renovation would be cost prohibitive and we'd still have an old building. And then ultimately what the county decided is one of the ways that we make this work economically is that we would be able to use the existing building, the existing Mountain View, for other county services and be able to consolidate some of our other services that are more administrative in nature, that those efficiencies didn't make a difference. The broader question is, or the broader answer is, every county situation is slightly different. We do see through the last several years, many organizations have moved forward with the replacement or refurbishment efforts. Some counties have, and this would even go back 20 years, some counties elected to get out of the healthcare business and say that that is not part of what the county should be doing. I think there's certainly a financial aspect to this decision, but there's also a core fundamental strategy on the part of the county and what services that you want to be able to make available to your residents. So I would say that I could probably give you an example of every different option that you can think of across the state, and every situation is just slightly different.
Thank you.
Michael, I have a couple of questions.
Make sure you're talking to the microphone.
Sorry, Michael. I have a couple of questions, including, looking at your recommendations under the strategic initiative skilled nursing slide. When we're looking at a projected flat or declining bed need, I'm wondering how to justify, adding additional amenities or services. And I know we're not talking apples to apples here. If we're looking at skilled nursing, as opposed to assisted living. So I'm wondering if you can speak to that a little bit. I'm a little puzzled about why we have such low numbers in this part of the state and why that need might be dropping. And that ties into our market area. And I understand how you develop the market area, but I'm also wondering if the market area hasn't really changed now since March. And in fact, because we have such a stellar track record here in Portage County, which may be attractive to certain people, if our market area isn't going to change a little bit post-COVID here, and I know we're looking into a crystal ball. So my two questions are, boy, if we're looking at a declining bed need or a flat bed need, I just don't know how to ask the county to support expanding services. I mean, I understand the rationale, how that would help, but I don't see that there's the numbers to support it. So I wonder if you could comment.
Yeah, so first, and maybe I was unclear in my recommendation. I just want to make my recommendation at this point is not to increase the number of skilled nursing beds. I think that is probably to be determined what is the right number of skilled nursing beds. So you're at 70 today. If you decide to move forward in the continuation path and potentially building something, really looking at what is the right number of beds, and it very well, to your point, could be less than 70 beds. I think going below 50 beds becomes very challenging in skilled nursing, because there are so many fixed costs that when you drop below 50 beds, you don't have the revenues to sustain really profitable operations. But somewhere, let's presume that it would be somewhere between 50 and 70 beds. And then really my recommendation was that you could look at whether it be assisted living or some of those other services to be able to provide other revenue streams to really offset that. So really getting it to the point is exactly as you said, is skilled nursing is not increasing in demand, it's going down.
Michael, you just want to speak to continuity of care, so that some, why assisted living on a campus with a skilled nursing facility has its benefits for potential revenue streams?
Yeah, so there's a couple of aspects there. Continuity of care is a big one. If we look at significant declines in geriatric or senior populations, transfers between services are an area where you see generally significant declines. When you have an individual that moves from an assisted living organization and then has to move into a unrelated skilled nursing, that is I use the term traumatic, but it's a big event in that person's life, and we often see significant declines. The continuity of care is nice and is certainly something family members appreciate, because you may have you can have continuation within one building or one campus where that person's disruption and needing those additional services does not result in as significant of a decline.
Do you have other questions, Ray?
I'm thinking out loud here, so I'm thinking of, if we offer other services, and I'm speaking as a former commercial contractor. I mean, I have never in my entire career seen a remodel on anything from a house to a commercial state building that was actually worth the money 10 years down the road.
I agree with you.
So what I'm struggling with is if the county decides to stay in this business, then what do we do with the old building? And is there a reasonable use we can put that building to? And can we actually offer other services out of that building while still offering the services we're talking about here in a new facility? And I know that's not quite within the scope of this study, but I'm just thinking about it out loud.
Well, and what Michael had just said about Mount View, which is the skilled nursing facility adjacent to North Central Healthcare, that's kind of what they did, is they found a way to use the less efficient skilled nursing areas for administrative function and other county things while doing the remodel, the renovation, the new facility for the skilled nursing. So it's a legitimate question, and it's something we can certainly explore. There's also demolition. There's all kinds of things. It's a big property once you start looking at it.
Sure.
So I think it's a good question. Is there a portion of that building that still has a use for offices? Something. I don't
Right.
know.
Is it cost effective?
Is it cost effective?
reuse
Because the
it.
windows would still need to be replaced.
Air conditioning.
Air conditioning, yeah. Yeah, most people who work in an office want air conditioning, so.
Yeah, again, my initial guess would be that it's not worth reusing that building, except on a very temporary basis, so.
Take the block
and
and
I'm
grind
also-
it up, make aggregate.
Sure, but
Yeah.
I'm also thinking about, and maybe this is part of what we're charged with here, but we have to sell this to the county, to the residents of the county, and I'm
Right.
thinking about, how do we sell this project, whatever the decision is? And so I'm truly just thinking out loud here.
Yeah, that is a big part of it, and that is why I don't know if you were at that meeting. Oh, anyway, one of the things that was very helpful the last time in advancing the referendum was the survey. St. Norbert survey, because what that did was create a lot of discussion, a lot of education. I did a lot of, I mean, the Rappies did a lot of outreach too on their own dime, as did Mary Ann on her own dime. I did a lot of outreach on my own time. You know, it takes, you have to have a media and outreach plan. I mean, if we're gonna do this, we just don't go, let's just keep it in the committee. And you're, you know, brick and mortar kind of guy. So the idea of a marketing plan, that's really another level of expertise, and that's easy enough to do. So, I think, because I do it quite frequently. But yeah, we'd have to obviously convince county board, but also the taxpayers, because very likely we're gonna need their help.
Certainly.
Yeah. Before I go to Mildred, anything?
Not right now.
Okay. All right. I will go-
Can I just add one comment on
Certainly.
that last question?
Sure.
So one of the steps that would be forthcoming is really to, depending on the strategic direction, is to look at a return on investment. And before you present anything to the county board or the county residents, is understanding what the financial outcomes would look like and what support you would need. So that would be something that would be part of the decision path for sure.
Yep. Okay. From the room, questions? Supervisor Dodge.
Not a question.
Oh, microphone.
I don't need to do that. I have to leave. I
Oh.
have another meeting.
Okay.
But I guess with the budget constraints that Portage County has, I think one thing that you have to look at when you're assessing additional services provided, you know, there is some part of the population that believes that government is not to compete with the private sector. And I think it's clear that we have facilities in the area. And if we grow our services, we will be in competition with them, and we are now. So I guess that's just a point that I'd like for you to consider.
I do that every day I go to work.
Right, we did it with landfill.
Yep.
Yep. Thank you, everyone.
Thanks, Jeannie.
Have a nice day, Jeannie.
Mary Ann, anything? Yep. Up to the microphone.
Mary Ann Leszewski, 1209 Wisconsin Street, Stevens Point, and we'll probably get into starting to repeat ourselves a little bit, but I keep thinking of the taxpayers. And I think our local taxpayers have observed that the open market is more than willing to provide plenty of assisted care facilities in our community. It's found to be quite profitable. And I think it's sort of unfortunate that Portage County would have to take on the expense of the management and building a larger facility in order for us to break even, or not even break even, but be viable. So with the increased cost of adding the assisted care facility, I think it's going to be a sticker shock for the taxpayers as opposed to approving a smaller facility. We have a referendum we'd have to probably put before them, and they're going to need to be sold not only at the cost of this facility, but the ongoing subsidizing it going forward. And when we were doing the phone surveys last time regarding people's interests, that they were more than happy in the referendum to temporarily tide us over and approve for a short period of time. But this is going to be apples and oranges. This is an entirely different ballgame. The only other additional service that you mentioned in your report that is not as available in Stevens Point are the 1- and 2-bedroom apartments for residents who can still live independently but might need some assisted care that are not being provided in Stevens Point at this time. And so I don't mean to repeat it, but we have a steep challenge ahead of us, unfortunately. Thank you.
I'm always up for a challenge. All right, I would go to then members of the audience online. And I'm going to try to, just unmute yourself and hopefully it won't create too much chaos if you have a question.
I have a question when you allow it. It's Nancy
Yep.
Roppy.
Go ahead, Nancy.
So in our market area, we'll call them competitors, by law could not turn away a resident who was a Medicaid being their only source, payer source. But if I'm not mistaken, they are not required to keep that person indefinitely. So in our market area, isn't the healthcare center pretty much the only place that will accept and retain a person whose only payer source is Medicaid? And that's for Mr. Peer.
Yeah, I'm not sure I could give you a definitive answer on that. There's a lot of factors that would go into a proprietary organization retaining a Medicaid resident long-term. And they would, in certain circumstances, retain those residents after they've exhausted their private funds. Is that always the case? No, I'm certain that it's not as well. So I think the answer is, they're not obligated necessarily to continue to provide services, but in many cases they would provide services long term.
Michael, there was a request to take down the PowerPoint slide.
Oh, yeah, I've started to do that and then I was afraid there would be a question on it. Yep.
Sure, no, that's okay.
I saw Chris had his hand up as well.
Oh, okay. Yeah, you would see the hands up. I can't see that. So go ahead, Chris, if you've got a question.
Yeah, sure. Thank you very much. And thank you for the presentation, Michael. It was very good and great conversation as well. My question is, I'm not sure you have a crystal ball on this either, but during your presentation, when you were talking about sort of other services, say the RCACs and CBRFs, right now there's not as much of a regulatory burden, but I'm just curious, like as maybe facilities move away from skilled nursing or diminish those services and some of them pop back up in RCACs and CBRFs, do you think that there will become a heavier regulatory burden and that might then influence operations of those facilities, just looking down the road as we contemplate all of the possibilities here?
Yeah, that is certainly a possibility, Chris. I think that in my mind, and this is an opinion, this speculative looking out, this is not fact, but I think that senior living has the ability to dictate how much regulatory oversight is implemented going forward. And what I mean by that is that if providers can continue to provide quality care, that license surveys continue to come back positively, I think that there's less pressure to add additional regulatory burdens. And conversely, if the industry does not, and you continue to provide services for sicker and sicker individuals inside of assisted living, then I would say very, very much that additional regulatory burdens and oversight will be put in place to ensure the safety of the elderly.
That's a good question. I thought about that too, because my ex-mother-in-law is in an assisted living that has some questionable practices. So hopefully we'll see good care coming out of those facilities so they don't have to have onerous sort of oversight. Other questions from members of the public online?
If not, Melissa, I have a question.
Oh, yes, I'm sorry. Go ahead, Ray.
So this is a question both for Michael and Chris, and I didn't ask it earlier because this may be more a question for corporate counsel, but I'm wondering Does the county have statutory obligations for care in this area that a private service provider would not? We do not?
No,
Okay.
no. Just like solid waste. Same thing.
Okay.
Or
Good.
or parks, or many other of the services we provide. Or corporate counsel. So really, if you look at chapter 59, it gives you the idea.
Okay.
So good question though. Or human resources department, but we're going to keep them because they're awesome, right?
Chair Johnson, can you repeat the question? It was hard to hear.
Oh, sure. The question was about statutory requirements related to skilled nursing, if there was any obligation. And of course, statute is silent on that. All right. Thank you, Michael. I guess the question is what direction did we want Michael to move forward with?
Well, I guess a related question also is, does CLA do market feasibility studies? And it seems like that's a piece we may need to look at here.
Michael?
So yes, the answer is yes. The market assessment that was in the appendix of today's report is a large component of that. The financial aspect is the other part of that, is understanding what does that look, what if you have a new operating model, what does that look like financially?
Yeah, the thing that I am most curious about is, let's assume the answer is yes, we want to provide some level of skilled nursing moving forward. In order to have that conversation that's making you a little nervous, we would need to know, and again, building that business model by having an assisted living, is the revenue from that, and you see it in solid waste. Landfills make lots of money, recycling doesn't. That's why we take landfill money to offset the cost of recycling when counties have both of those. It's very common. Take your revenue stream and distribute it out among, vertically among your business units. We use it to support our hazardous waste program. So if it's that component, assisted living, and I've long thought that would be the case because I know that there's money to be made there while still providing quality care and having that continuum of care to create that less disruption, make it more attractive. Also having on-site services like, again, dialysis, so that they don't have to be transported out. We're not spending time doing that. All of these things to create that efficiency. And again, I feel fortunate having gone to a skilled nursing facility that had just been built over in Winnebago County. And so I learned all of that in that trip, and now you can't do that. But ultimately, my question is we go on that route, and let's say it's just a skilled nursing facility at 54 beds. Let's pick a number. What does that look like for capital? And what does that look like for operational costs? With an acknowledgement, we know we're going to need less staff, all of these things. What is the amount that we're going to need from the levy that we would have to ask taxpayers for? We already know they were willing to support us for $1.4 million. Will they want to do that into the future? I don't know. That's the question I want to ask. So that's kind of where I am. And then the next one is, what does that business model look like with the added amenity of continuity of care, along with some of these other services, to create those efficiencies? And I think the third question, and this again, I've already checked again with Michael Loy, who is the executive director at North Central Healthcare. They are willing to pay for, if we make this choice to sort of make an option on looking at staying in the business. And maybe after doing all of that, we all go, we just can't do this. But if we go down this road and we look like we have some fairly attractive numbers, North Central Healthcare Marathon County is very interested in a collaboration to create efficiencies across a regional healthcare system. That option is there. They're willing to put nearly $10,000 into that just because they're that interested in it. So,
Sorry.
yeah.
Sorry, I didn't mean to cut you off.
No, go ahead, Dennis.
I'm mindful of how quickly 2 years have gone by.
Yeah, I
I'm
know.
mindful of, we have, it seems like a long time, but we don't have much time.
No, we don't.
And also, I thought that you were right to say, hey, we have to make some decisions here. So what I'm afraid of, I don't want to spin our wheels and, like some of the decisions we've done at the county level, we've talked about for 20 years and now we're still no place. We don't have the luxury of doing that here because, the stakeholders I've talked to said, hey, it's just a matter of time before something happens, or it's a matter of time before they shut us down and then we no longer have any options.
Right.
So, and we know right now it seems like there's 4 options out there. And it seems like at some point in time we have to decide which of those 4 options we're going to go and then pursue it with vigor. And before we do that, I'm just wondering, is there any more information that anybody wants us to have before we have that discussion, or is there anybody who has any information they need in order to have a meaningful discussion in that direction? And I'd like to have that, whatever we need to do, I'd like to do it over a compressed period of time so that we have something to go ahead and we can focus our energy on one thing rather than having these 4 options out there forever. And what I don't want to have is an elongated study coming back and we're in the same place we are now where we haven't really bit the bullet and say, okay, let's bare our hearts and the souls here. What do we think should happen? So,
Absolutely.
and so I'm just wondering if there's information that people on the committee still need or want, or there's information that you or our consultant would like us to have before we have that meat and bones discussion.
Before we have, well, I want the financial information. I mean, I run an enterprise fund.
So that's something that you would want, and then we need to find out how long it would take us to get it and what it will cost us then.
And again, maybe that's a question for Michael, and again, not talking actual dollars, but if we're talking about a partnership between 2 counties, in this case Portage and Marathon counties, what does that really mean financially for Portage County? How much of a...
That's what this analysis would do, right, Michael?
Right. Yeah, looking at specific, positions and functions that you could share, potentially benefiting both organizations and inputting dollars to that.
So Michael, if you, are there existing collaborations like that between other multiple counties in the state? And is there even a ballpark number of what the reduction in costs might be for a county? Meaning, does partnering with another county save any individual county, 20%, 30%, 40% on a project like this? Or do those numbers not exist?
Yeah, I would prefer not to put out a percent tonight. I don't think we've done our due diligence and specifics to be able to say that. But North Central also has collaboration in different services with other counties. So yes, they certainly exist out there.
And will part of that report then be also to see how our mission statements match up? Because as I talk to some stakeholders about that option, they say, hey, it doesn't work for us because we have the mission statements aren't close enough, and the services we providing would be so diverse that it may not be a good match. So just not only in terms of the metrics of the economy of it, but just in terms of the service and make sure that is well meshed. If that could be part of that presentation, that'd be helpful.
I'm wondering, Michael, there may be value in having Michael Loy as a part of this sooner than later, and I certainly can check with him to see if he's available on the 30th. Again, Michael is a department head colleague of mine, and I've had many conversations with him. They currently are now the administrative component of Pineview, which is the Lincoln County Healthcare, our skilled nursing facility. They took over that role, I don't know, she's...
a year ago?
Year ago, thanks. Yeah, it was about a year ago. and have turned things around quite nicely. So I think there's opportunity. I do think, so when you say the mission and the vision, and maybe I'm biased because I work for Portage or Marathon County, but I see alignments in our core values. I see alignment in our mission. So
I don't know.
yeah, yeah. But it's a good question. We want to make sure that our, if we do something, what's our biggest asset? Employees, right? At least I think. It's not the building, it's not the beds, it's the employees. You don't do anything without employees. Your number one asset. So you want to make sure that employees are well cared for within that core value system. And then make sure that we're aligned with how we treat and value patients. That is clearly an important component. And then, of course, captured within that, I think, in a core value discussion is how we manage our resources. Because we want to be good stewards of resources. We don't want to go off on a harebrained sort of chase. We want to make sure that we're giving good value to not only the people within the facility, but the stakeholders, the taxpayers who are supporting it. So that's the kind of alignment I would like to see.
So it sounds like that particular report is something that you want and that'd be helpful for all of us, I'm sure.
Yes.
But what kind of a time frame then are we on for something like that?
I'd have to ask Michael on that.
I don't think it would be a long time frame. We have to get Michael Loy involved, but I don't think that would be a long time frame at all.
I've already got a note to call him first thing in the morning. So, yeah.
Just speaking to the group then, is there anything else that would be helpful before we have this discussion to help us narrow down our options? Is there anything else that anyone else is needing as far as information so that we're not coming to the next meeting and saying, okay, now what do we need?
Great.
Or anything else that you could offer too, or Michael?
Well,
I might pose one more question. I apologize if somebody raised their hand in the room.
Go ahead.
But and not necessarily needing to answer this today, but for certainly any committee members on the or constituents in the room, defining what success looks like. Financial success, patient care success, I think is something as we work through this and having a clear vision. So for instance, financial success, Melissa, you talked about the current tax levy. Maybe success for one person would be that you maintain the current tax levy. And another person would say, we think that there should be no supported, that's success. So understanding what that is as you move through this process and having a clear vision, I think will be another important aspect for the group to consider.
Yeah, very good point. Very good point. Mildred, did you have anything else? Okay, no. So we are interested. We're not saying immediately that we want to get out of the game. We're saying we're curious enough. We feel an obligation enough to get additional information on.
I think if that's valuable, I don't think we can move forward without people having that if it feels necessary.
Okay.
I have to admit, I'm stuck. I mean, if I was asked to make a decision tonight, I would say get out of the game.
Yeah.
And so I'm worried about how long a window we're looking at to get this information back that would allow us to decide if Portage County can actually stay in the game.
It's not going to take long.
Okay.
Yep. Unfortunately, this should have been done last spring. We can't, woulda, coulda, shoulda ain't going to work. But if we can agree, after my hissy fit last time, that we are aligned in making a decision and get the right kind of information, get a decision, and move forward.
Sure, I'm ready for that discussion.
Okay.
Yeah,
Yeah, I am as well.
Right. Then I'm glad I had a hissy fit.
Melissa, do you have any idea what the cost of the next study would be?
Well, we have some costing information built into this study.
Michael, can you comment on that? Or?
Yeah, the next phase being the discussion with North Central Healthcare.
Mhm.
It would
And
be
just-
it would be contained in this scope of work, so there would be no additional
Yep.
cost.
Yeah.
Well, that's attractive.
Yep.
I do think that the next probably, depending on what you decide, but the next probably significant dollar outlay would be engagement of an architect.
I agree.
If that's a decision you decided to pursue.
Yep. I agree.
Michael, and, oh, sorry.
Oh, go ahead, Chris, and then I'll go to Mildred.
Okay, thank you. It's just in relation to the North Central Healthcare conversation. And I don't know the answer, but I think maybe Michael or Melissa will be able to shed some light on it. Because as I understand it, they're essentially they're a private sector entity running these things on behalf of the public sector. And so my question is more along the lines of how and when, or is it necessary for the county structures to talk to each other, whether that be healthcare committees or county? I don't know who all would be involved in that, or if North Central has kind of the ability they have already.
They do have some independence. That's a good question, Chris. And I think having county leadership have that conversation sooner than later. Trying to wear many different hats when I say have had conversations with county board chair and with my previous boss, Brad Carger, and my new boss, Lance Leonard. So there is some awareness, and of course, North Central Healthcare does have a board, and Michael works collaboratively with them. They do have to go to Marathon County to ask for resources, and so it is important to start having that discussion. Good question.
I do think, just to add on to that answer, that both Brad and Lance that you referenced, we've certainly had conversations. They understand the value that can be brought through a collaboration model. So I don't think that's a significant hurdle, but one that certainly needs to be addressed.
Yeah. I think the other thing is Marathon County's strategic plan, the 2020 to 2025. One of the strategic goals is to work collaboratively with other counties to find ways to manage costs across those continuums. So it is aligned with that particular, and I'm sorry if I keep talking about Marathon County, but I spend more time with Marathon County than I do at home in my private life. But so I think there's a lot of alignment. Will it be? I don't know if it'll work, but it is an option, and I'm looking forward to that information. Do you have enough information to proceed, Michael?
I do.
Okay, and you blacked out the September 30th at 5 p.m.?
I was going to check that. I believe I did.
And we would be back in this room. I already have this cleared. I just want to say, while we have a lot of people on the phone and online right here, the city of Stevens Point is not charging the Portage County for any of this. So I'm grateful for that. Casey's time back there. Thank you, Casey, for being here. City of Stevens Point is covering those costs. So.
Thank you.
It's my turn now. Back to me.
Yep.
Okay. I've had trouble trying to figure out how to say this, but it seems that what the healthcare center has done, it's provided a key part. To me, the key part is a skilled nursing that it's provided for the county. And we're looking at how to kind of run a business. And I don't know, I'm trying to separate out what is the service that we see as really important to provide locally for our residents. What is the service that we want to provide? Not what are the things we can add to make a business viable. Now, I know You know, we've got to deal with the financial side of it. There's no question about that. But somehow there seems to me to be a difference in looking at what is it that we want to have locally for that and affordable for people in this county and surrounding areas. But to me, that's what I have seen that the healthcare center does. It provides services for the local area, and so getting expansive about building a business that's going to survive. I don't know. There seems to me maybe there's some there's a different way we could look at it that might help decide what we want to do. And if we're coordinating with another county or something in a bigger group, maybe we decide what is it that we need local. I don't know. So that's the best I can say it now.
Thank you.
I think, Mildred, the question you're asking is what is the core thing that we do? And again, absolutely, we provide excellent skilled nursing service. And I'm sorry, and I apologize if I kind of leap into all of business modeling, but I run a business within county government with the core mission of providing solid waste services for central and north central Wisconsin. In order to make that affordable, I guess my brain is just so keyed into thinking in those terms that I automatically go there because I know that's what has to be done. In order to, it's kind of like, here's our value, this is what we want to do. In order to make that happen, I have to go here to build that business plan. And so if I've leaped there, I'm sorry, without connecting those dots, but you're right. What's the very base of what we're doing? Trying to provide the best skilled nursing available for central Wisconsin. So,
Mildred, I would also say that one of my main concerns is I think that this really is a service, and I think staff have done a stellar job of providing this service. But I also feel as a county, we have not financially supported staff. I mean, we're forcing this to do this on a shoestring, which is not how it should be done.
Right.
And so the reason I'm looking at the financial end of it is not just to act as a steward of the county's financial resources, but to ensure that the staff actually have the budget to do this well. And I don't feel that we've done that in the past. So we've been very lucky to have that standard of care at a substantially reduced cost. And I don't think we have that luxury much longer.
nope, I agree.
Or should have it.
Or should have it, right.
All right. Send Michael on his way and ask him to get busy. I will contact Michael Loy tomorrow, and I'll connect with you, Michael. And
Sounds wonderful.
let's get this going. You want to give me back control over my screen?
Yes. Actually, I don't have to, do I have to give you control?
Oh, maybe not. Let me see. Who's trying to chat with me? Oh, that was Jenny. Let's see. Screen. Disable host screen sharing. Okay. Come on.
There you should have it. If I needed to do that, you should be able to take control. And when I exit, it'll revert to you
Yeah,
as
it'll
host
revert to
anyway.
me. All right. Thank you, Michael. We
Thank
look
you.
forward.
Thank you, Michael.
Yep.
Have a nice
Take
evening.
care.
Thank you to everyone.
Thanks.
All right. Bye.
Onward. We have one more topic. Thank you. Great discussion. I just want to say that you're all making my heart very happy for being here and having this discussion. I feel, thank you.
Thank you.
Thank you. All right, moving on to the CNA wages, the next item. So I don't know who's going to be taking this one on. Laura, Marcia,
Not leaving.
Jenny, I don't care who.
I guess we provided you a lot of documents. The one thing in the first bullet point that we wanted to just update you is that during the budget discussions, we've had conversations and heard feedback from this committee, as well as Melissa on HR committee, from I think healthcare center staff, is that there is a want to move to the general schedule, feeling that the healthcare salary schedule, first of all, isn't used to, or hasn't been used for what it was intended to, and that it seems to not be using its purpose, so move them into the general schedule. So we did cost that out and are looking to go ahead and see if that's a possibility. I know Chris can talk to that too in regards to, what he plans on putting in the budget or not. But what we did is we took everybody and put them on the general schedule with the thought process of when we implemented the salary schedules, that everybody would be placed on the general schedule, whatever gave them an increase in a step that gave them an increase. The approximate cost in wages only for that would be about $20,000. So fringe benefits are not included in that. But then I guess that was just an update for the committee, and maybe, I don't know if Chris wanted feedback from the committee, if that's where they would like him to go, or if he has any more thoughts on that. I have not had a conversation with him probably in about a week in regards to that, so maybe turn it over to Chris.
What's the percentage on the benefit package? Is that usually like 30%, 32%?
In the healthcare center, it really depends because of the health insurance is so variable based on hours worked. So I wouldn't really want to quote an amount. Sure. So I don't know, maybe Trish or Jenny would be more comfortable doing that, but.
Oh, sure, no problem. That's $20,000 isn't a lot of money, and even if it's around 30% for, it's a lot of money. I can't write out a check for that today, but. You have a question, Dennis?
Is it okay if I ask something?
Absolutely.
My question, just a little background history as to, and maybe someone on the line knows too, but what was the rationale to not have them on the pay schedule? And if there are any negatives about having them on the pay scale other than the $20,000? Is there anything else we should know about that as far as the decision?
Well, the reason for putting them on a separate schedule is Victoria McGrath, when she did our salary schedules, and she's very familiar with public sector government, knows the financial stresses that healthcare centers can have, and knew that we were in that same situation. And if you look how and I'm sorry, I don't think I included in the documents, but our general schedule, has steps 1 through 20, and you are committed to percentage increases for those steps. So it's 2% increase just in the steps alone, not if you do a cost of living to the entire schedule, but it's 2% from step 1 to step 2, and then 1.5% all the way up to step 9, and then 1%. So you're committing to those every year. Right now, we set up the healthcare center schedule, so at least you had a starting, and then to step 5, which is market. So the goal is we want all staff to at least be paid at the market. Anything beyond step 5 to step 20, so it was a cap of, these positions shouldn't go over this amount. But there was that amount that didn't have a set amount. The thought is it would give the healthcare center then the ability for the majority of employees, once they reach market, that they're not going to be paid less than market, but then they could decide how much money they could afford to give for increases every year and not be tied to set percentages. So it could be, we can't afford a 1%, we can afford to get everybody a 30-cent raise. We can afford 1%, we can give a 0.5%. You are tied in the general schedule to whatever the county chooses to increase.
Call Nolan.
Excuse me?
So
Whoever.
that might just be a ghost. But
Yeah.
so
I just want to say you're tied to then whatever the county decides to increase the general schedule. So this year we're talking about 1%, and then you're tied to if the county chooses overall, unless you want to carve out an exception for the healthcare center, but then you can't do that in your cost of living. You could do it with steps, but then you have morale things of everybody else gets a step, but healthcare center doesn't. So that's why there's a separate schedule. The separate schedule is a tool for the county.
So the negative is that already fragile system, if we move forward to it through years to years, and it could become even more fragile because now their pay scale, they're going to get paid at a more enhanced level than what they might be otherwise.
or you're tied to certain
Right.
things that you weren't necessarily before, yeah.
Thank you.
So I guess is Chris on the phone?
He was
mean-
there. He's there.
He's there. I mean, the executive makes the budget in collaboration with the department heads. And is this something we can ask to have done?
I think Chris has been very good about wanting input from committees so that the budget, when it is presented, is something that is a collaborative and more likely to move forward, would be, and I don't want to speak on behalf of Chris, but I know that's what he has come to the committees a lot of time for input, so.
Yeah, and I'd say that's accurate. And I think, we are entering into that phase where we're figuring out if there's a deficit, and if there is, how big is it? This is something that's certainly on the table. But we wanted to update you all tonight. I've talked to Marcia and Lynn about this as well, just to make sure I understand from them and their team's perspective, like of the items that are all being discussed in your meetings, like what are their thoughts? And so as we move through, this is, even the 1% cost of living adjustment that Laura had mentioned, that's still a question of whether or not it can be given to all employees. Certainly, it's a priority in terms of wanting to, but until I have a better or a closer, more final idea of what, if there is a deficit and how big, then that will frame a lot of the steps and decisions that we have to make moving forward. But this is definitely on my radar screen, and staying on top of it, and definitely interested in your input.
Is this one of the reasons why when we look at starting pay for our healthcare providers, that they're kind of in the market, but when you look at max pay, we're not quite in the market anymore because they've been, kind of tampered down a little bit. Is that accurate or
No,
not?
because the max pay is part of the whole schedule, so I would say too that I thought by looking at it, we were about the same in starting and max pay.
Well, some
I
graph.
saw a discrepancy there.
Yeah, there's some graph and I can't read it with my funny
Yeah.
glasses.
So when I put in the documents too, you see there's the 3 different sheets, and they are all the same data, but just sorted differently. So the one sheet is just the wages, but then if you look at the other ones, it's one sorted by the wage, by the starting wage from
Yeah,
low to high.
that's what I was looking at.
Yep, and then the next one was the max wage, low to
Yeah,
high.
and there were clearly, for the one, we're actually right in the ballpark with everybody for the starting wages. But when you look at max wages, we're probably less than, not majority, I suppose that's
This
true.
right here.
Yeah. Okay, there are some who are higher, but not all of them.
Yeah, so starting wage, we're at the 90%, and so max wage, we're at 95.
Okay.
So, like I said, they're very similar. So the max wage, at that step, that last maximum step, that goes up the same as your step 1 when we do the cost
Okay,
of living.
thank you. Thanks
so.
for clarifying that. Appreciate
Yep.
it.
Mhm. So I guess, what we would be looking for as staff too is that if there's interest from this committee, if the committee says, no, we're not interested, we would like to use this tool, then it would help us in knowing where we put our resources and work, and that would be another, if we don't want to go forward with something that the committee said, that's not what we asked for, that's not what we want. So I guess that would be from our perspective too.
What are your thoughts as the director? Do you have some thoughts?
Again, I think the consistency is very, very important. The other thing that we've never been able to do, I know part of the intent of developing it this way was, quote, if budget allowed us to. Well, we've never had, no one's had frivolous budget to put in it, so we've always felt if we were monitoring and trying to do it, if we could build it in our budget, we really truly could not. So I think thus we felt the consistency.
How many employees would this impact?
Right now, I believe we have approximately 140. Many of those are casual, but I think that was our most recent testing load. So those are people on our payrolls.
See, this is, and I don't know where this would fall, but one of the things that bugs me a little bit is that here we have 140 employees that we know that in the short term it'd be 20,000, and we know that as time goes on, of course, that number gets bigger. And we're going to weigh that heavily, obviously, because we should be fiscally, conservative. However, just recently, for 6 or 7 employees, we just passed $50,000. So that's the kind of,
Yeah.
it just, because these people they're at the bottom of our pay scale, and they're doing the most honorable work, and especially right now, the most honorable work. So, and I know that you have to balance the budgets. I'm all about that, and I know you can't say yes to everybody, and you can't, we have realities with the budget. But this is one of them I'd hope that we're able to look at closely, and I know Chris will, but it seems to be, when you look at the big picture, it's like, yeah, this is one that we should really be advocating for. So, that's my 2 cents.
And maybe this is a question for Chris, but Chris, are you looking for a consensus among the committee? I would guess that all of us sitting here tonight would agree with what Dennis just said, that we, as a committee, we would really like to look at this and see if we can't help with this compensation a bit.
But I'd also like to hear from Chris. If he thinks that, hey, this is going to break our budget down the road, if it's really step into quicksand, I'd like to know that.
Yeah, no, and that's, I would say that the discussion you've had has been very informative for me, and I'm sure staff, in terms of just hearing where you're at. I think most of kind of the intention or idea behind the conversation mirrors, at least, definitely what I've discussed with Marcia and Lynn. So even looking at the various options, like if you could do 1 or 2 or 3 or those sorts of things, like knowing where some priorities are. And I think this is a kind of a bigger picture sort of move than the others. And so I think that, knowing that, we can dig a little bit deeper and then fully appreciate all the different aspects to it. I think we got the costing on it last week after we crunched the numbers and had a rough estimate, and we can look at the benefit side and then, do some trending and projections to see, how this might even fold into, the other, all the other conversations you'll be having. So it'll just be another data point, but yeah, this is very helpful. You don't need a vote. It's the sense, I understand where you're coming from, and I'll incorporate that into my thinking for sure.
Thanks, Chris.
Thank you.
I'd just like to make a statement that I think we should not have any employee starting wage less than $15 an hour. If we want to lead and work to circumvent poverty in this county, and sorry if I'm going to be making a political statement here, but the Alice report indicated that almost half of the families in Portage County are living in poverty. That is unacceptable. And if we are leaders, true leaders, we would set the standard and say no employee will make less than $15 an hour. So if we can, I think that's a benchmark we should be looking at to set that trend, because we are the county.
Yeah. Respectfully, I'm not sure I agree with all that, but I do know that these people should not be starting at less than $15.
I agree.
I just feel strongly about that.
I do too.
But there may be positions in our county, like I'm thinking, we hire a seasonal, we hire a high school kid, a college kid to come in and do X, Y, Z, whatever. There might be positions that would be appropriate.
I'll qualify that with maybe those seasonal, although I pay my college interns that, so.
Yeah, well, I'm just saying, I'm not sure I would agree with it, but that's not our job, is we don't have to do that. But
So,
in this particular
absolutely.
case, obviously, these people,
All right. You have some direction there, Chris?
Yes, thank you all very much.
Thank you. Thank you for asking. All right. I think we were also talking about hazard pay.
Well, the other bullet that we had on here, because there was conversation, and it was the CNA wages.
Oh, CNA wages, sorry.
So I didn't, if I know last time it was more of we just think there needs to be something with the wages.
Yep.
So I don't know if this is what then you were looking for, and then there is nothing else at this point, or if there were other items that you wanted us to be reviewing and looking at.
I had a question for,
Go ahead.
do we know?
Oh, there
the-
was, I'm sorry, I didn't mean to interrupt, except
No.
someone online was
Go
saying.
ahead, take
No,
them.
someone online said they were having difficulty hearing, so,
Oh.
I know, the masks are,
right.
so make sure you're speaking as loudly as
Yeah.
possible into.
I'm just wondering, for the hazard pay, potential hazard pay, is that funding available from other sources, or that's come out of our budget?
Depends on what you decide. So for hazard pay, that would be another thing is, I know I talked to Jenny and Tricia this afternoon, and they might be able to speak to this more. The routes to recovery, I think it would have to be a payment before November 6th. There are other funding sources, but Jenny would have to look into more detail if this type of hazard, what you would deem hazard pay. The hazard pay is a definition under the routes to recovery. The other funding sources, it might not necessarily be deemed hazard pay. She would have to see what would be available under those and research. If you wanted to do something beyond that, it would be on the county's money.
So it's a potentially, this could be on the county then, potentially, the hazard pay, potentially. And the
Correct.
second question is, and Jenny, I think she alluded to this last time, but I said, if this committee does advocate for this for our group, is it likely that other groups in the county will be doing the same thing, and therefore it becomes I don't know what the word would be, but it would just gain momentum, the same. And so I just wanted her input on that, or her reflection on that. Whether we're opening the door for other departments asking for hazard pay.
Well, are you talking about hazard pay under the Road to Recovery Act, CARES Act?
Yeah.
Or, okay, because they'd have to fit that definition, right?
Correct, and I would say you could potentially be opening a door. I think it depends on how you define it. And what reasoning you give of why you want to provide the hazard pay. And what you think deems warranted by the hazard pay.
Okay, thank you.
But it seems like there are pretty clear parameters there in the way it's written down. Or that was my takeaway.
Speak up, Ray, if you could, just make sure.
So my comment was, it appears that there's pretty clear parameters as to what is or what does or does not qualify. And so in a way, that's a safeguard for the county.
I would say,
Wiggle room, that's our.
yeah, I think it was subjective. I would say it's not as clear as I would as a
Physical
administrator
hardship, and
feel,
that's-
but
have you ever-
define hardship, correct, yeah.
Exactly.
Okay.
Yeah, I mean, I could see corrections officers probably falling into that, and quite frankly.
Officers, even road officers.
Maybe,
Yeah.
maybe, but definitely corrections officers because they're, have that one-on-one. But maybe the onus in defining it is more specifically, what are the details of the tasks we're trying to define that we feel are so over and above that this is why the hazard pay is necessary. So what are those, key points, 3, 4, 5, whatever they happen to be, so that we make the argument, here is why we believe this falls under that. And let's say the sheriff's department is successful in doing that. If that's the case, and there is COVID funding to cover that, it certainly seems to be, they should be entitled as well. So, but our job, I think, is specifically for the healthcare facility. What are those key additional jobs that when they were hired are just so over the top because of COVID and that additional work that they have to do? So if we could define that, I think that's, and Tammy's back there, I think she's already got like 8 things. Marcia probably has a few more, and Lynn has a few more. Then we can say, this is the rationale we are using as the Healthcare Center Committee for recommending hazard pay for CNAs and LPNs.
I guess my question too would be, is what's the ultimate goal? Is it that hazard pay is an opportunity to get more pay for our CNAs and employees right now, so we're gonna try to define how to get that? Or is it, we feel that these things happen due to COVID,
Right.
and explain to us if hazard pay will be a method to reimburse for that. So I guess we'd be looking for input from this committee of what duties or functions or things that are different with COVID that you feel we should evaluate and see if that falls under hazard pay, if that makes sense. Otherwise, if it's just we want to find a method to provide them more money, there's other opportunities to get additional funding.
Yeah.
Or money, not funding, but money. So, I mean, and there's an opportunity with funding here, but the opportunity is short.
I definitely see this as really related to COVID, as really related to that level of care that's just beyond anything they thought was going to be possible, any of us would have thought possible, and it would have to sunset. When we finally can talk to one another without masks on, and we can hug one another when we greet one another, wouldn't that be great?
Right, but what about if COVID, let's say it could go on,
Sure.
and the hardships for our staff could go on for several years yet. It's potential.
Yeah.
Let's say that the COVID funding is the next 6 months, and then that money's not there, and we've already said, hey, we're going to do hazard pay. That's what I'm concerned about, is that we are.
Tie it to the federal funding.
That's one possibility, I guess. I'm just really concerned about, and I know that we have a responsibility on our committee, but we also are board members for the whole county.
Absolutely.
And what we do certainly has an impact on what other people are going to do, how they do it. So I am very strongly in support of an increased wages for them. Right now, though, I'm still very, very uneasy about the hazard pay. What I'd have to know is A, that everything that we do would be covered, and B, that it'd be so specific that it doesn't open the door for some very loose-leased definition of a physical hardship. I've just seen it so many times before where when you put that kind of element into such a diverse group of employees that it gets messy. And I don't want it to be messy. Sometimes by validating this group, we put everybody else at a negative, and our morale right now is really important, not only for our healthcare providers, but for all our employees. And I don't want to set a situation up where we say, well, they had hardships, but you didn't, and they say, hey, you didn't walk a mile in my shoe because this is what I had to do. And so anyway, that's my concern.
Yeah.
I'm sorry.
No, go ahead, Laura. Oh. Go ahead, Laura.
Okay. I was just going to say, if you look at when Carrie did the contacting out to different county nursing homes, if you can see, one of the questions she did ask is the hazard pay amount and who has hazard pay. So you can see that in there. So I guess that would be one of my first questions is, looking at the information of what other facilities have done. Is a hazard pay something that, first of all, you would want us to continue to pursue? And then it would be, if you could see those who said yes, you can see what are the parameters. Right. So, if you look at Rock County, they said yes, and they said it's when there's COVID-19 positive residents. So they defined it, when there's a positive resident, those who have to care for the resident get hazard pay. Then you can see that Vernon County was $10 an hour if working in a COVID unit. So again, defined with there being positive cases of COVID. And those staff who are required to work with those residents. If you look at Sheboygan, same thing, $10 an hour if working in a COVID unit. So a lot of it was tied once they had a positive, and those staff who were working with those residents who had COVID, they got the hazard pay.
I like that, because then if it's, let's say the jail, I don't know what they call them, jail keepers, what?
Inmate.
Corrections officers.
Corrections officers. Then if they had someone who's COVID, then I say, yeah, now it's apples to apples. So I think that type of definition really helps me out, because then it's like, okay, yeah, now I get it. That group is working specifically with people who have COVID, and if you're working with someone who has COVID in your position, let's give some consideration then.
Except, I mean, that's an easy place it's a safety zone, to call it that, to say, this is it fits in a box. I'm so happy it fits in a box. This doesn't fit nicely in a box, And just because you'd have to wait for a positive COVID doesn't mean that you're not doing all the things. You're still doing all the same things, whether you're tending to a COVID patient or not tending to a COVID patient.
We're almost penalizing staff for
Yeah, good point.
doing such an incredible job,
Yeah.
right?
I think the thought concept is that they are putting themselves personally at a point of contracting the disease, and that's why they're being reimbursed, because they're taking it home to their families, and they might have to be more careful. If they're working with a COVID patient every day, they might not be able to go home and feel comfortable visiting their mom, you know, who's an elderly person. So I think those are the things that sometimes why it was, if you're working with a COVID patient, you probably, you know, are obviously at a higher risk of contracting COVID, so.
And I support that rationale completely. I'm struggling with how to compensate staff for the measures that they have to go through right now to ensure that we don't get those positive cases, which
Tammy.
is also a huge piece.
You can come up to the, you gotta come up to the, gotta come up to the microphone, ma'am. I know you put a lot of miles on every single day, but you just gotta walk up here.
My other point too, I just wanted to make too, is that we could have exposure and not know it for days. I mean, until they're symptomatic, until they're tested, every day we go into work, we have a potential to be exposed. We don't know. We don't know until it's too late. It's already done. And just the extra work, I mean, COVID has changed my staff's world drastically. They're everybody, they're everything, they're doing more, they're expected to do more. You know, now we're closing down the rehab unit, we're integrating those people, so we're adding more residents to the same staffing levels. I mean, it's just, we're asking for so much. And the other thing I just want to say is, I keep on hearing about these wage studies, and I'd like to throw them out the window because they make me crazy. I don't care. The industry, healthcare industry, is struggling to find CNAs. We are utilizing our RNs. We're utilizing our LPNs. We're utilizing me to work as CNAs because we don't have enough CNAs. Why is that? Maybe because the industry has an issue, and that's our wages are not sufficient for the job. I mean, I'm sick and tired of hearing about wage studies.
Yes.
Just wanted to make sure.
Because they're inadequate. I mean, have we looked at the community? Have we looked at what everyone else is paying? No, we haven't. We look at the industry. Well, the industry has a problem. There's not any CNAs because they don't have to be a CNA. It used to be way back 10 years ago, CNA work was, you know, something you'd go into. You could actually make a decent wage. You can't do that now. You cannot say that now. It is not a decent wage. It is, like you said, it's a poverty level. I mean, and some of my staff have to work part-time. They had to limit their hours because they can't afford to, even if they're working full-time, support a family. So they have to be on support from the community, from the government, because it's not a livable wage. Something has to change. If we don't change it, seriously, we're gonna be out of business. We won't have any CNAs to work for us, to do the job. I mean, I don't understand why we're okay with paying an LPN, we're okay with paying an RN, we're okay with paying a director of nursing to do a CNA job, but we can't look at the wage for the CNAs. So, that's my point.
Thank you.
Well said. Thank you.
Thank you, ma'am. So Laura asked us some questions. Do we want her, so I think there's two things. Laura certainly could, and her staff, I'm not saying you would do it, Laura, and her staff to help us define this, but I think I would like to ask staff at the healthcare center to define this. We've been talking about it. I would like to see it in writing.
And her. Yeah,
Yes?
I'd like to see that too.
Yes?
Agreed.
Yes? Okay.
Is Chris still with us?
Chris, you still there? Are you still with us? It's like he's gone forever. Sorry, it's been a long day.
Chris?
Yep, I'm here.
Hey, what are your thoughts regarding how widespread the request for hazard pay would be, or how we could handle that? Is it something that we could have where we could do it proactively, just say we are going to give the following people hazard pay, and just do it ourselves as a county rather than each department advocating for it? Is this, what's your thoughts? I guess I'm asking.
Well, I think you would have to be very specific. I agree with your sentiments earlier as well. Also, just because that's already happened in some regards. Like there are a lot of departments who have they didn't say we want hazard pay, but they say, well, are you thinking about hazard pay? What's the hazard pay situation? And it's not like I'm trying to say people aren't in more difficult situations because of COVID, but we have the same thing with layoffs where some departments felt it's not fair that other departments are getting laid off while they're not, or teleworking. So I think the atmosphere in general is tense around a lot of these questions, which is again why I think if you do it, you need to get very specific so that the parameters don't lend themselves to interpretation. But I certainly understand that some other counties have put some of these things into place. I've actually reached out and talked to them about how they did it, what was their rationale as a part of this discussion as well. So I think in the grand scheme, I see things very similar to how you expressed them earlier. And yeah.
Have you heard any good ideas? I'm sorry, Chris. I thought you were done.
No,
Go ahead.
No, I am done, sorry.
Yeah. Have you heard of any kind of parameters that we could put in place that would help someone who's concerned about it spreading too thin? And what are they doing that makes sense to say, yeah, that's going to tighten things up a bit? Is there anything out there that you might be aware of?
I can actually speak to that. We had internally in our department today, we're kind of throwing around some of those things. So we have a concept that's kind of started that we'd be happy to bring back.
I would love
Again,
to see that.
It was on the agenda. We've been doing research on it. The other thing is we wanted to, again, see if this is something the committee wanted us to pursue. We're not in favor of always pursuing things that aren't going to get supported. So it takes a lot of time and work. So we actually need to focus on what's needed. The other thing is just don't, other things that we've been looking at and looking back at this, was helpful for us too, to say, is it per hour? Is it a flat, a lump sum?
Yeah.
Again, knowing that if you're doing it per hour and the time that we have right now if you want to fund it somewhere else, that it's not going to be a lot. So is it something that you want us to be looking at a lump sum or a per hour? And so we can define it. So I guess the first question was, do you want us to still pursue hazard pay?
Yes.
Okay.
I would say yes.
Okay.
With a couple of caveats. One is that I do want to know that whatever is developed is going to be tied to the federal funding.
Yes.
And not in isolation, not on the county. And the only thing I think about the honorarium that makes sense for me is that I think it was you that came to the meeting and showed everything you had to do. That's really the hazard part, and the whether you're on the job for an hour or 6 hours, that is the physical, the extra thing you had to do. So I'm just wondering if we could do, my thought is like an honorarium rather than hours, so everyone's treated fairly, because whether you're there for an hour or 6 hours or 8 hours for the day, that risk is just the same for you in the course of the day, because you can meet that one patient in your first 5 minutes. So anyway, that's just my thought.
I think donning beyond just a mask for PPE or gloves was something that we had noted today. Donning above and beyond PPE, the face mask, the gloves, the whole, I think we saw them get all dressed up before, and then, knowing that you're working in the summer and the additional heat with that on. So that was something that we did note that we could say, that is something that can concrete. I do caution, we hear teams say their jobs have really changed a lot since COVID. Everybody's going to fall under that category. Sorry, that is not something we can put in there, because my job has changed greatly. I mean, every county employee's job has changed greatly. So that definition cannot be used. I'm just going to tell you that. And I can say that with 100% certainty. But again, so if you want us to go with the concept, and we can continue to work on what we were looking at and bring something back for September 30th. It is helpful to know that was one of my other questions of if it would be fully funded by an additional source, then that it has to fit in that box.
To me, it would be a dead issue if it were not using CARES funding. I would not proceed with it for myself.
Okay, so I think, and again, if you're open to different concepts of maybe not exactly just a per hour, but, in lump sum was something else that some others have done, so that we can go down that road and bring something back for September 30th, if that's.
And talking specifically about our healthcare people, I think they just want a little love to say, hey, we see you. We actually recognize that what you've done, and when you talk to the providers that we have, these are people who are passionate about what they're doing, and they're not getting the compensation that most people would probably agree that they do, but just to be able to do something for them to say, hey, we appreciate what you've done, and we understand the risk you're taking for those that you care about, and I think it'd be nice. So
I agree.
on the other hand, I don't want to open up to wackiness either.
Yeah, so another thing that we had, I just lost something that you had just mentioned that we were talking about, but, direct patient care. So that was maybe a definition too, that, we could. Correct, yeah, and then, so, like I said, defining it very clearly is something that we would need to do, so.
And when you write that up, I'm sorry.
Yep, go ahead.
When you write that up, will you write, so it's not just it won't necessarily just healthcare people necessarily, because the definitions should be something that we can use maybe throughout the county and not just, but.
Sure, yeah, I mean, it would actually, I think along the thought logic that everybody says, yes, because of that makes sense, so, corrections officers were somebody who was identified.
I just don't want you to have to see you do this for like 10 different parts of the county.
We do not want that either.
Yeah, we want consistency.
Yeah.
Thank you very much.
Yeah.
All right. You've got direction? Are you good?
Yes, the only other thing that you can see, we had 3 bullet up there and the CNA wages survey results. So I guess that would be my question, is if we address the hazard pay and putting them on the general schedule, is that what you're looking for from our department, or was there anything additional from us?
We're good? Okay.
We're good.
Good discussion. Great. And Marcia and Tammy and Lynn, you got direction on helping us define why we need to know. Okay. Awesome. I have low battery life, and I'm going to lose everybody online in 19 minutes as my laptop shuts down because I forgot to plug it in. I brought the cord. So, all right. Excellent. Thank you so much again, everybody. It renews my faith that we can get things done. Our next meeting date is September 30th. We will meet here again. It says annex, but that is not correct. We will meet in this room again. And I would entertain a motion to adjourn.
So moved.
We have motion by Risser, second by Robbie. All those in favor, please say aye. Aye. All right, we are adjourned at 7:17. Thank you very, very much, everyone. Excellent discussion tonight. Thanks, everyone online. I appreciate you attending tonight. The Zoom information will be sent out in advance of the next meeting. Thanks, everyone. Stay safe, please.
A video of this meeting is available for viewing on the city's website, stevenspoint.com/videos.